Good morning. Welcome back to OpenMedSchool, the skill development program in neurological disease. In the last session, we have discussed about localization, that is, where is the lesion? And we have discussed that the anatomical localization is made by the symptomatology. Today we will be discussing about what is the lesion, that is, what is the etiology of the disease. So, neurological diagnosis should be done in a stepwise manner. First question is, has this patient got a genuine neurological problem? Second is, where is the problem? That is localization. Third is, what is the problem? That is the etiological diagnosis. Let us see how we will arrive at an etiological diagnosis. Most neurological diseases, the diagnosis rests on the history alone. Most of the time, the diagnosis by history, the localization and even etiology can be obtained from the history. Past medical history often gives clues. For example, somebody is diabetic. It is at a high, these patients are at a risk of developing many neurological problems. So, knowing diabetes gives an etiology. What may be the likely lesion? Second is the history of medications. For example, somebody coming with a seizure disorder, most often discontinuation by forgetting the anti-epileptic drugs or errors in the dosage leads on to the problem. Third is family history. Even for common diseases, not only for genetically transmitted diseases, even for common disease like migraine, the history will give a clue. And history of use of alcohol and recreational drugs are two important things, often gives the clues to the diagnosis. Again, underlying medical condition. For example, somebody with a liver disease coming with altered sensorium, immediately you will think about either a hepatic encephalopathy or a complication of liver disease leading on to bleeding into the brain like a subdural hematoma or intracerebral hematoma even. So, underlying medical diseases like liver disease, a cardiac murmur, atrial fibrillation, all gives clues to the etiological diagnosis. But the most important thing, you remember, the localization is by the symptoms, etiology usually by the clue is by the time course. That is the temporal progression of the disease gives a clue most often to the what is the likely etiology. For example, somebody comes with the weakness of one side of the body, that is hemiplegia or hemiparesis. We can localize anatomically it is due to a corticospinal lesion, that is an upper motor neuron lesion, that is corticospinal lesion. But if the etiology is a vascular accident, the onset will be abrupt. That is, the patient says yesterday he was normal, today morning he developed this. This indicates a vascular, that is acute onset. The same symptom the patient may be having for the last 1 week and is gradually progressing. That means it is not vascular, it is something which is enlarging, that is, it is a space occupying lesion. So, same anatomical problem or anatomical lesion, the etiology is different and it is the clue is by the time course. Or in another word, you can say the temporal progression of the disease points to the etiology. Hope it is clear. So, let us little more detail into the time course. Some disease can occur in seconds, that is called hyperacute onset. Some of them occurs over minutes, it is acute onset. Some over 72 hours, and the disease may come back to baseline within a day. For example, somebody with a transient ischemic episode, the weakness occurs abruptly, but it may progress less than 24 hours and the patient may go back to the normal. Sometimes this may return to baseline after several days or weeks, or the disease may progress over weeks to months. So we will discuss this in little more detail in the following slides. So this is somebody brought with a history of falling unconscious. So this has occurred abruptly within seconds. For example, somebody with a seizure, an epileptic episode, it occurs within minutes. So this is an example of a hyperacute presentation. Another example, somebody is talking, suddenly developing weakness of one side of the body, within minutes it occurs. Both these are examples of hyperacute. That is, hyperacute means the onset is within seconds. The typical examples are vascular accidents, stroke, epileptic seizure. So always remember these 2 points. That is, stroke will always have a definite onset. This can occur abruptly within seconds. In such case, it is called hyperacute presentation. Next, we take history of a patient falling syncope. That is, transient loss of consciousness due to decreased cerebral perfusion. So this is never abrupt. It occurs over few minutes. Patient may get a warning and then falls down. So the presentation can be within minutes. So typical example is the vasovagal syncope. The patient develops a premonition. They try to avoid the fall. Sometimes vascular accidents. Stroke can also be like that, over few minutes or several hours. That is a stroke in evolution. It progresses for some time. That is an example of a acute presentation. Then toxins and metabolic conditions. You can also somebody with hypoglycemia. But again, remember, hypoglycemia is never very abrupt. It occurs over few minutes. The patient may have, unless the patient develop a convulsion due to hypoglycemia, most of the toxic metabolic conditions presents little over few minutes or few hours can be there. So that is an acute example of acute presentation. Then subacute, that is the 1, 2 or 3 days it may progress, over few days it occurs. Typical example is delirium. So delirium is acute in onset, but sometimes this may progress little. Toxic and metabolic conditions. Most of, for example, hyponatremia. Most of these things are usually or may progress over a few hours. Then inflammatory conditions. Somebody with meningitis, encephalitis. Unless they develop a complication like a seizure, it again progresses over few days, 2 or 3 days it may be there. Then in immune mediated conditions, that is demyelinating illnesses, again progress over. Presentation can be acute, but at the same sometimes it can be little subacute, or it may progress over few days or a few hours. Then subdural hematoma is another example. Myasthenia gravis. The patient may be developing some dimness of vision due to the development of malalignment of eyes, followed by the ptosis and other external ocular manifestations. So typical example is myasthenia. So this is again subacute presentation. Sometimes neoplastic disease also can be subacute. Then another typical presentation is remitting and relapsing. That is, patient develop a symptom or signs, then it subsides completely and again it recurs. That is what is called remitting and relapsing. So let us take transient ischemic episodes or transient ischemic attacks. Most of these things occur abruptly, last for a few minutes, disappears. This may recur later. So that is an example of it remits and relapses. It occurs and again later sometime it again recurs. Some periodic disorders, example migraine. Recurrent episodes of headache can occur, but in between the patient is normal. Another example, epilepsy. Again it is remitting and again it may recur again. Or somebody with myasthenia. Again the patient can have diplopia for some time, patient may improve. Again after some time, it may be after months or years, it can recur. And sometimes they may not return to normal within few days, but it may take few days or weeks even. Example, multiple sclerosis. One attack of multiple sclerosis occurs, the deficit lasts, and after some time it improves completely and again it may recur. Second example is toxic and metabolic problems, drug-induced problems. It may not come to normal within one day, but it may take few days or weeks for complete remission. So remitting and relapsing is typically seen in demyelinating illness like multiple sclerosis, but this sort of presentation can occur in other conditions which we have discussed. So this is the time course which usually we describe, that is abrupt onset, one episode occurs, completely recurs, again another episode. So this is remitting and relapsing. Hope it is clear. Some of the diseases you can say slowly progressive over months or years, and sometimes the disease may be progressing, in between there is another episode, one episode, again another episode, and it may gradually progress like that. So diseases can present in various ways, remitting and relapsing, then slowly progressive, or in between there is progressing, in between there is some stuttering, that is some episodes occur in between. So we'll look into what is stuttering episodes. For example, stroke-like syndromes due to vasculitis. So patient develops one episode of a hemiparesis. After some time, patient can get one more episode. Or somebody has got an endocarditis. Today he developed one embolic episode. 2 days later they can get an embolic episode in another part of the brain and can get a recurrent episodes, a stuttering progress. And myasthenia is another condition. Can come with ocular manifestations, may come with diplopia. 2 days later the patient may develop a weakness of the other muscles. So stuttering progression can also occur. Then most of the chronic conditions, they are chronic progressive. Progression occurs over weeks or months. So anybody has got a disease which is progressing like that indirectly indicates that this is likely to be either a space occupying lesion or a degenerative condition that is occurring over several weeks or months. So Alzheimer's disease and motor neuron disease are typical examples of degenerative conditions. Over several years, months to years it progresses. Malignancy, again it may be a little more rapid progression, but again the presentation will be a gradually progressing one. It grows, gradually progresses. Guillain-Barré is another example, but it's not months, but for a few days to 3 weeks, maximum 4 weeks it may progress. So the man may progress to up to 4 weeks, reach a plateau and then come down. So this is example of progressive disease. It can be either weeks or months. So we have discussed the time course of the most neurological diseases. So can occur in seconds, that is what we call hyperacute. In minutes it is acute. Over 72 hours. It's a rough guideline only. You can call it as a subacute presentation. Then we have said about the remitting and relapsing. So there are two types. They may return to baseline and again recur. That is the remitting and relapsing. Sometimes it can be a stuttering course. That is, the disease will recur repeatedly, stuttering course. And we have also discussed the chronic progressive disease as in degenerative conditions. And degenerative condition, the chronic progressive can be either in weeks or months. These are the things which we have discussed today. And after a careful history, a localization, and then identifying the etiology from the history and other medical, the past history, family history, social history, we go into the examination of the patient. And examination, think the body in a grid, that is, think about the body right and left. Is the disease affecting the right side, affecting the left side? Then in a systematic order, you plan the level of lesion. The level can be either at the involvement of the higher mental functions, involvement of the cranial nerves, then the spinal cord, plexus, peripheral nerves. Then you ask the question, is it human or element? And once you consider this, you go to use the medical examination to complement the neurology. That is the cardiac examination, abdominal examination, respiratory examination, rheumatological examination. So other system examination is also must to come to a proper diagnosis. And investigation without localization or without a clinical diagnosis, less likely to give you the answer. So you have to ask the proper question, right question, then only you will get a correct answer. That is about the investigation. We will discuss these two things in the subsequent lectures. So in short, friends, neurology is not about knowing where the nucleus ambiguous or nucleus accumbens, or nor about treating very complex cases. Around 35% of the patients coming to a casualty or emergency department is having some neurological problem, and that is the importance of a systematic approach to neurological diseases. Think clearly and logically about the problem. Focus on the problem without losing sight of the patient's wider medical and social context. Think about the medical disorders, think about the social context, and deliver appropriate advice and care when the patient needs it most. That should be the aim of a neurological examination.